Beckjord. I'm the Associate Vice President of Population Health and Clinical Transformation at UPMC Health Plan. And it's my pleasure to introduce our first keynote speaker, Dr. Deirdre Cooper Owens. She is the Charles and Linda Wilson Professor in the History of Medicine and Director of the Humanities in Medicine program at the University of Nebraska-Lincoln. And she's also an Organization of American Historians Distinguished Lecturer. Her first book, Medical Bondage, Race, Gender, and the Origins of American Gynecology, won the Darlene Clark Hine Book Award from the Organization of American Historians as the best book written in African American women's and gender history. Dr. Cooper Owens is also the director of the Program in African American History at the Library Company of Philadelphia, the country's oldest cultural institution. Currently, she is working on a second book project, a biography of Harriet Tubman, that will examine her life as a person living with a disability. In the afterword of Medical Bondage, Dr. Cooper Owens writes, "What my work as a historian of race, slavery, medicine, and gender has taught me is that the legacies from the 19th century are always present in our lives as Americans. Unlike the Black women who helped birth gynecology through their sufferings, I have a platform that allows me to reveal how Black women still negotiate their lives as medical superbodies." We are grateful to have this session be a part of your platform, Dr. Cooper Owens, and to begin today's advocacy session, hearing from you and our panel members about how historical context must inform today's efforts to achieve health equity. Please help me welcome Dr. Deirdre Cooper Owens.
Okay, I started the timer because I can talk a lot. So thank you all so much. I am not going to share names. I just want to thank every person who has been involved with making this summit a positive one, a productive one, and one that has run seamlessly. So from the organizers, the administrators, from those who are volunteering their time, all the way to the security guards out front, thank you so much for allowing me space to share my work with you. All right, so let's see here. So I write about dead people in the 18th and 19th century. I am not a medical doctor. It seems as I end my talks, people will come and tell me all about their medical problems, and I'm like, so I have a PhD, and I write about people who lived hundreds of years ago. But what I do think is important is putting the past in conversation with the present. And I used to get, when I would give these talks about the history of American gynecology and its intersection with race and racism and gender and all of those things, I would get, well, yeah, that's then. What about now? So let me talk about then. So the guy pictured to my far left is Dr. Samuel Cartwright. Some of you might have heard of him. Others, you might not know of Cartwright, but he was pretty famous during the 19th century, during the antebellum era. And Sam Cartwright becomes famous because of two things. So one is an article he writes about the racial differences between the Negro and the white person. And so he essentially studies the Negro. They were all enslaved in his study. And he comes up with a number of distinctive Negro diseases. One of them was drapetomania. So if the Negro slave ran away or harbored the thought of running away, they were mentally ill. The other was rascality. So if you're a little sassy, that was also a distinctive Negro disease. And there were a number of others, right? Unless you think Sam Cartwright had time to do this, he was actually asked by the Louisiana State Medical Association to do this research. A decade or so later, Sam Cartwright continues his comparative-based research on the Negro. And for him, the Negro was synonymous with an enslaved person and white folk. And he does this, so if you kind of look towards my left, you'll see a picture of a book written by Lundy Braun, recently retired medical anthropologist of Brown University, but she writes about the spirometer. It's a wonderful book called Breathing into the Machine, and so that's an image of a 19th century spirometer. Cartwright did not found or create this, this tool, but what he did, he researched using the Negro in the white population to see if the Negro actually has a lessened lung capacity, based on the writings of Thomas Jefferson and other thinkers and researchers of the day. And he found that, in fact, the Negro did have a lessened lung capacity. Now, Cartwright was a slave owner. Cartwright knew the conditions of slave housing. And so none of those factors entered into the ways that he interpreted the research. He simply said the Negro has a lessened lung capacity. Why was this so important? Well, at the start of the Civil War, the United States government, notice I said US government, not the Confederate States of America. The US government, through the US Sanitary Commission, decides that they are going to use these new tools, one like the spirometer, to assess the biological differences between Black and white people. And essentially they were doing this to find out really if the Negro was fit for freedom or slavery, right? Which is why Samuel Cartwright was asked in the 1830s to conduct this research, right? Which is why his research made such a splash. The enduring legacy of medical racism is that, and I'm speaking to doctors, right? MDs, you all know this. The spirometer is still used to assess lung capacity, and yet you have to reconfigure it to address race. And as I look out for the virtual audience, on the walls we see DNA strands and molecular, the imprint of molecules all on the walls. And we know that human beings are 99.9% more similar than dissimilar, and yet we are still using the medical practice of the 19th century to assess whether Black people have a diminished lung capacity with the reconfiguration of numbers, right? And so when Dr. Taylor just talked about addressing the structural or the systemic, right, concerns around inequities, it's embedded even in things that we consider value neutral, like the machines that we use. Now, if we move towards medical racism now, okay, let's see, is this clicker working? Dr. Kelly Hoffman in 2014 decides that she is going to do research for, of medical residents and staff at UVA's medical center. Now, unless any of you graduated from UVA's medical center, I promise you I'm not picking on them, I did my postdoc there. People are very proud to have been affiliated with UVA, right? Mr. Jefferson School. So it is one of the nation's top-ranked institutions. And so we're talking about medical residents. So these are people who entered into medical schools with a 4-year degree. Not people who are coming from high school, not people who are coming from, I don't know, I forget the name of that little commercial where Master P, the rapper, and his son, they're not coming from there. They're coming from places where they have already earned bachelor's degrees. And yet when Kelly Hoffman and her research team does a sample study of these residents, overwhelmingly, the white students believed in the biological differences between white and Black people. They believed Black people had thicker skin. Black people had a propensity to age faster. Black people didn't experience pain, even for very painful conditions like kidney stones or childbirth. This was in 2014. The report was published in 2016. You can Google it and find out all about it. And so essentially, what these students chose was not what they learned from their professors in their undergrad institutions that have been teaching for decades that race is a social construct and not a biological construct. They intentionally chose anti-Blackness because it is embedded in this society. They forewent all of the scientific training that gave them those bachelors of science degrees and bachelors of art degrees, and they consistently chose anti-Blackness. 2 of the residents actually reported that they believed Black people were born with tails. This is the 21st century retention of that 18th and 19th century medical racism that we're still grappling with today. So how do I come into this, right? In 2017, I was an assistant professor of African American history at Queens College, and all of a sudden, my professional life really changed because students across the nation were protesting the statues on their campuses and their town squares that revered the lives and contributions of these Confederate soldiers. And New Yorkers, and I lived in New York at the time, was teaching at a college in Queens, New York. New Yorkers thought they were safe. Oh, we're the North. We don't have to worry about those kinds of things, except in the far easternmost corner of Central Park in East Harlem was a statue dedicated to James Marion Sims, known as the father of American gynecology. And for almost a decade, there had been a grassroots initiative led by Marina Ortiz, a Puerto Rican activist who learned about Sims and his experimental work on enslaved women in the South, and so she wanted the statue removed. It wasn't until a group of 4 women, members of the Black Youth Project 100, decided to stage an artistic and political protest that the issue really becomes well-known nationally. And so they donned themselves in hospital gowns, splattered with red paint to represent blood, and they were essentially representing the enslaved women that Sims operated on. We only know the names of 3 of them, Anarcha, Betsy, Lucy. And so the picture goes viral. And I remember it was in late August, and I remember my inbox is blowing up. I'm getting phone calls and texts. Hey, why didn't you tell me about this protest? And I said, what protest? And they're like, the one in Central Park. And I was like, no, I didn't have anything to do with it. But my editor calls. And I had a Black editor at UGA Press. And so he calls and he says, hey, we're going to publish a book early because we need to ride this wave. And so I had a choice as a professor, and particularly a professor who studies race and medicine and racism and gender. How do I answer these questions about whether the statue stays or remains, or do I give myself the space to essentially serve as someone who can educate people about the past and contextualize it for them? So I didn't play nice, right? Everybody wanted to know, should the statue be removed or should it stay? And essentially I said, guess what? Whether you remove the statue or it stays, and I'm not saying the symbols aren't important, the Black maternal health crisis is gonna remain. The Black birthing crisis is gonna remain. And so that's not a question I'm really interested in answering. And a large part of this is because the way that American history has always been taught is great men or great women of history. So we know certain people's names. And we don't think about the kind of structural or systemic impact of what those characters helped to create. So a large part of it was, right, newspaper articles like this by Lauren Saucer of South Carolina's Post and Courier. And South Carolina is the birthplace of James Marion Sims. And so she writes, savior of women or medical monster, the front legacy of South Carolina's most infamous physician. And so all of a sudden, what that does is it creates in the American mind a historical boogeyman. So now we can blame everything on Sims. Sims created this idea that Black people don't experience pain. Sims intentionally drugged his patients. Sims didn't ask for their consent. I mean, all of these things were swirling around, and here I was, someone who studies the past and is constantly trying to contextualize it to say, wait, historical boogeymen don't serve us, right? It doesn't mean that Sims needs, that I'm defending Sims. Trust me, he lived a very good life and he does not need my defense. However, I wanted to be able to have people think about this a bit more critically. And also, I wanted to get rid of the exceptionality narrative. So, the first page of my book, right, American Medical Bondage, the origins of American gynecology, my first sentence says, the first hospital dedicated to women's health was located on a slave farm in Alabama. It's not the one that Sims has been credited with founding in New York in 1855. And I don't have to make this up. In fact, a man wrote a whole memoir for us, right? I'm not really good at creative fiction. So I simply use the sources that he left for us and his colleagues. And what I also do in that first chapter is I give you a litany of folk who did this work well before Sims, starting in the 18th century with Georges Cuvier, who was a natural historian scientist. He worked on the body of the South African-born Saartjie Baartman, or Sarah Baartman, derisively known as the Hottentot Venus. And most people wrote about her from the perspective of, oh, you know, this woman was treated poorly. She became a kind of circus freak, or the size of her buttocks, or how her body influenced Victorian fashion. I wasn't really interested in that at all. I wanted to know how Georges Cuvier, who was the head of the research department at the National Museum of Paris, how did he write about Baartman scientifically and medically? How did he treat her, right? She lived in a menagerie. I know that sounds really nice, but it's a holding for animals and plants, right? So here was a South African-born woman, right, who was enslaved on the continent and then carried across the ocean and essentially owned by white men. And so by the time Cuvier has custody of Baartman, he is really interested in trying to figure out, is this Hottentot woman, is she the missing link between the human and the primate? And he wants to examine her body, and he has the chance, he has the opportunity, because she dies very young at 25. At the very beginning of the 19th century. And so he goes about conducting an autopsy on her cadaver, and guess what he finds? That she's a normal human being. The medical condition that she was assigned, steatopegia, the enlargement of the buttocks, all of that was essentially racist, right? I lived in South Africa for a few months, right, a few years ago. Trust me, she was shaped like any other South African woman, right? And so yet, they've medicalized her, they pathologized her, and they took out her brain, preserved it, put it in a bell jar, cut out her genitalia, preserved it, put it in a bell jar, and took her skeleton, displayed it until 1974. So from the 19th century until the 20th century, and they didn't do the, you know, they didn't stop displaying it because of ethical concerns. They stopped displaying her remains because her genitalia and brain were lost. So what that taught me was there was even a value in the afterlife of an enslaved person. What do their remains serve the medical community in terms of pedagogical or teaching purposes, right? And those ideas and practices literally traveled across the pond, so to speak. And so by the beginning of the 19th century in the new country, the United States of America, you have someone like Ephraim McDowell, who was also a slave owner, who was the person credited with performing the first successful abdominal-based incision. He did so on a white patient, removing a 21-pound ovarian tumor in 1809. And this is really important. The date is important. Typically, I'm not the historian who cares about dates, but let me tell you why 1809 was so important. Because the Constitution banned the African slave trade in 1807. So by 1808, the United States had to figure out, how do we bring more Africans, how do we create more African people in this nation to do the work that has begun to create wealth, immense wealth for us? Reproductive medicine and care. And so Ephraim McDowell in Kentucky, right? He scours the county looking for cases. Guess what? All of them are black. Now, my husband he's from a place not too far from here in West Virginia. And he's I tease him, he's an Afro-Latchin. There are not many black people living in Appalachia in the 21st century. There certainly were not a lot in Kentucky in 1809, right? 4%, in fact, in the county where Ephraim McDowell lived. And yet he managed to find 5 black women, negresses as he called them, to perform ovariotomies on. One of them died. He does so for almost 10 years, publishes an article in 1817. He thought that he was going to change the face of American medicine, and he was derided. And let me tell you why. In fact, a British physician, a Dr. Johnson, writing in The Lancet after learning about McDowell's surgery, declared, well, of course, He operated on negresses because they bear cutting with the impunity of dogs and rabbits, animals known to reproduce fast. So this idea that James Marion Sims created the notion that black people didn't experience pain already existed, right? Once again, this is structural. John Peter Matthau, in fact, he performs the same obstetrical fistula, and it feels really good not to have to explain vesicovaginal fistula to a room full of physicians. I'll just say that. So I'm going to take it that most of you know, right? But he repairs this fistula surgery on an enslaved woman and a white woman. Guess what? Another slave-owning physician in the South, like McDowell. The white woman is cured. He uses a silk suture method. The enslaved woman is not. In his words, he writes, "The patient could have been cured had she stopped engaging in sexual intercourse." Sir, you are a slave owner in Virginia. You know good and well, even in the 19th century, that enslaved people don't own their bodies. In fact, you wrote that you performed these experimental surgeries on her over a number of years for 8 trials. Dr. Matthau's words, not mine. And he also does this while he founded the Randolph-Macon College of Medicine. It's now defunct. But he was also institution building and producing knowledge. He publishes his research. And so although in the 19th century, the way that his statement, had she stopped engaging in sexual intercourse, could have been interpreted, she's lascivious and oversexed and these immoral folk, cannot, they just cannot maintain their passions. What I am interpreting that statement as in the 19th century, slavery becomes, if I can use a 21st century term, a negative a social outcome. It becomes a challenge, right? The woman who doesn't own her body still has to engage in sexual intercourse. Perhaps it's forced, perhaps it's with a husband or a romantic partner, but she has to work, she has to engage in sexual intercourse, and she also is experimented on. Francois-Marie Provost, father of the C-section. These are names that are not as well known as Sims, but he was French-born like Cuvier, gets his medical degree in Paris. In 1799, he decides he and his young wife are going to move to France's most economically valuable colony, which is Haiti. And he begins experimental research on Haitian enslaved women, trying to perfect the cesarean section. Now, there's something that messes up his plans. There's a little wrench thrown into the plans. He gets word that there might be a revolution. We later learn this is the Haitian Revolution. So he skedaddles, and he goes to a former French colony, now a part of the United States, Louisiana, and settles in Donaldsonville, Louisiana, and begins the same experimental work on enslaved women in the 1830s. And in fact, is credited as the second American to perform this feat successfully. Now, let me tell you, history is not always linear, but in this case, their enduring legacy of anti-Blackness remains. This is how linear it is. Francois-Marie Provost does these experiments on Black women in the 1830s in Louisiana. Until the 21st century, Louisiana was #1 in terms of the disproportionate use of Black women who had C-sections performed on them. From the 19th century, the 20th century, and the 21st. And it remains in the top 3, lest we think that this is not structural. So when folk were coming to me and saying, oh my gosh, Sims is a horrible person, and I'm saying that may be true. But if we implicate him, we have to implicate all of them. Because this isn't about a historical boogeyman. These are about examining the building blocks that creates a Black birthing crisis in the United States that makes this country, in terms of high income earning nations, the most dangerous place for a Black woman or birthing person, not to just become pregnant, but to give birth. And this also affects the lives of their children. That has been enduring since the colonial era, the new national period, the 20th century, and now the 21st century. Those stats have rarely changed. The difference is, where you had a government and a slaveholding region who was concerned about the reproductive health of Black women, not because they were benevolent, but because by the start of the Civil War, the US South is the fourth richest nation in the world. In the world. And why they're really concerned is because in the colonial period, as far back as the 1680s, the British colonial leaders do something that they had never done before. They literally changed the law that says children are to inherit the condition of the father. No, no, no. Because there were so many children being born to white men, right? By enslaved women. All of a sudden they say, wait, we must change this law, per tu sequitur ventrum, and now we'll say that the condition of a child born to an enslaved woman is passed on to her from, or him from the mother. And it is the only law in all the colonies. I mean, we can name all of the European empires that set up these kind of slave-holding nations, but it is the law that endures until the end of the Civil War in 1865. So where, and this is a picture of Sims, right? So where does this leave us, right? As I was attempting to do this dissertation research way back in 2005, and I'm going to archives as a grad student, and I was always told, oh, that's cute. That's really cute. Maybe you'll have enough to publish a pamphlet. All of the surgical developments happened during the Civil War. And it's hard to write a history that centers enslaved folk when they didn't leave a lot of written records, right? I mean, so I'm writing about people and they were illiterate. And so I have to take pieces of information from the fragments that remain and from the archival sources that these white medical men left us and piece together the lives and experiences of these women. And also lay bare for us in the 21st century the ways that all of these racial cognitive dissonances cropped up, right? So I'm dealing also with the erasure, the historical erasure of Black folk and slavery from the development of American medicine. And a large part of that has to deal with the images that emerge, right? The folk who were writing about it were very clear that they were performing these experimental surgeries on Black folk. They would say slave, negress, servitor, all of the euphemisms for someone who was considered chattel property. They were not shy about it because why did they have to be? This was normal. But all of a sudden you started to have these editorial choices where the text is talking about Black folk, but the images don't include Black people. So all of a sudden, Sims's nurse is white, the patient is white, she's clothed, she even has on nice shoes. Sims is simply holding her thigh and her leg, and the white nurse is inserting the speculum. Where the reality is, Sims had these women on display for a crowd in his Montgomery, Alabama hospital. And these women were naked because Black women were thought to be immodest. And the surgeries were performed publicly. Now, let's get to the issue of, because I have 3 minutes and 52 seconds. I want to abide by this 30-minute timeline. So let's get to the issue of why didn't Sims ask consent? Because they were not considered human beings legally. So he asked their owners, and the owners said yes. Oh, was Sims, was he a compassionate physician because he took on the financial cost of caring for them and housed them? That's what you did when you leased property. You can go read Frederick Douglass's many iterations of his autobiography to learn about how he was leased. Harriet Tubman was leased as young as 6 years old. That was quite normal, right? So of course he would take on the cost. He's repairing property. The other thing, wait, but he gave them opium. He was trying to, or opiates, he was trying to drug them. No, that was used quite regularly by all physicians. The other thing, wait, but Sims made them work. Well, when his 2 white surgical assistants left, he did what most slave owners do. They make enslaved people work. It's an economic labor system. What do you think they were going to do, just sit in the beds, right, and recover? No, they had to go and cook and wash and all of these things. Now, this is the racial cognitive dissonance for me that comes up. Sims writes about how they were restrained because he tries the silk suture method, he tries a lead suture method, he eventually creates a silver suture method. And this is over a period of almost 5 years. And he's doing this on Anarcha, Betsy, Lucy, and about 6 other women, maybe 5 or 6 other women, whose names were not in the historical record. But he writes about restraining them. This is the thing. If black people don't experience pain, why are you restraining them? If black people are biologically different than white women, or in this case, black women are biologically different than white women, why are you experimenting on them to cure white women? The racial cognitive dissonances are just there, right? Also, and I have a really big mouth, I had to keep this quiet for a long time when I founded at the National Archives. The youngest member of the slave community that Sims owned and managed was a 2-year-old mulatto girl born during an experimental trial in his hospital. Remember, miscegenation, or the mixing of the races, was illegal. And yet a white man impregnated this enslaved woman who was undergoing an experimental surgery, and she produced a white child. So if there is a biomedical ethical violation that endures from the 19th century to the 21st century, it's that. So where are we now, right? What is the legacy? And this is a picture of the hospitals that Sims owned where these things happened, which is the first institution founded for women's health in the country during the antebellum era. So where are we now? The legacy of medical racism, you know this. Black women, black birthing people, 3 to 4 times more likely to die from pregnancy-related complications than white women. Just as my colleague said earlier, you go to certain cities. At the time when I was living in Brooklyn, that number was 8 times more likely. In Pittsburgh, right, like many Rust Belt cities, so I don't want you all to think that Pittsburgh is exceptional in this way, right, in terms of the abysmal birthing crisis. Pittsburgh, right, black women are more likely to die during pregnancy than their peers in 97% of US cities and birthing people. Fetal deaths are 2 times more likely among Pittsburgh's black women and birthing people compared to white women and birthing people. In any Rust Belt city, you will find that the stats are similar. And what we now know, right, among many of the things that black folk have literally been saying for centuries, that it is not their race, it's not black women's weight or birthing people's weight, it is racism. Rachel Hardiman, who is a public health researcher and scholar at the University of Minnesota School of Public Health, found, right, in her study from 1992 to 2015, so the late 20th century to the early 21st century, she found that when black women and birthing people had providers at every level who looked like them, the morbidity and the mortality rates were cut in half. So it's racism. It is that enduring anti-blackness that people continue to choose. And that's where we start. How do we teach people to give up something that they have invested in, but that doesn't serve us? And so for me as a historian, a part of that challenge has been to ask folk, right, to think of black women not just as objects of our scorn or scientific inquiry, but to really see them as subjects who demand our care, our compassion, our respect. So I thank you so very much, and I look forward to the conversation that we'll have in just a few minutes.
Thank you so much for such a wonderful keynote. And if I could please welcome the other panelists to the stage. Dr. Idalis Flores, professor at Ponce Health Sciences University School of Medicine. Dr. Cherie Livingston, OBGYN department chair at UPMC Litsit. Dr. Hai Simhan, executive vice chair of obstetrical services and director of clinical innovation of the Women's Health Service Line at UPMC. And Dr. Doug Jacobs, the Chief Medical Officer and Chief Innovation Officer for the Pennsylvania Department of Human Services. Would also like to recognize and thank Meg Sheed for being here, the Acting Secretary of Human Services, who's joined us from Harrisburg today as well. Hello, everyone. So I'm going to start with a general question for anyone. In light of what we've just heard, how aware do you think most people are of the historical context that's so important for understanding health inequities today? And do we have a foundational need to raise awareness of historical context as part of our work to improve health equity?
I'll start. I think it's really important to raise that awareness. I think Dr. Cooper Owens' talk did that, I think, for this audience. And the cognizance of history, not only as some distant context in the way things used to be, but as really a continuous process that in some ways we're still living in, is really important to be able to remediate and improve moving forward. So I think it's critically important for these kinds of historical messages to be part of learning today.
And if I can, I think to the first part of your question where you ask how many people are aware, it's complicated. Mm-hmm. Black Americans are aware, even if they aren't able to say, oh, Tuskegee by name, or oh, James Marion Sims. They're aware through the ways that their experiences continue to mirror that of their ancestors, right? The generations before. So there has been something unchanging, but I know when I teach my students, and I am at Lincoln, Nebraska, let's just say that some of you would double the size of the people of color population in Lincoln, right? If we all moved there right now. I teach largely white students, because Lincoln is a very white state. None of them are aware. None of them are aware. And so I think that question is also reflective of the ways that things are still divided. They're rent in this country with regard to race. And so certain communities know, whereas others are either unintentionally or willfully ignorant about it.
The next question is, anyone can respond, but Dr. Livingston, Dr. Simhan. We've heard some about the current state of disparities with respect to women's health and infant health and people of color, but happy to hear more from you about the current state, but also would love to hear about the comprehensive care models that are becoming more reliably implemented and available, including models that extend into the community and provide community-based services, and how that's an important part of improving outcomes for people of color in maternal and child health care.
So comprehensive care models are just that. It's a team approach to providing care. And it's extremely important in addressing the issue of maternal morbidity and mortality. Black women are 3 to 4 times more likely to die in childbirth. 22.6% of COVID deaths were amongst Black people. 50% of preterm birth rates, 50% higher in women of color. And so these are issues that we have to take. As a Black OBGYN, as a Black woman, this issue is very pressing for me, and I take that to my workplace every day. And I say, what is it that we can do? And what we can do is create this team approach, because just as a physician, I can't fix the problem. A nurse alone can't fix it. Doulas, who are wonderful, can't fix it alone. And so what do? We create this team approach, and we say the best way to provide the care to women in most need is to create this comprehensive care model. And so I created the Diversifying Doula Initiative, where we said, let's make more Black and brown doctors, let's make more Black and brown doulas, and create these pathways. But guess what? It doesn't start in medical school. Mm-hmm. Keep in mind, the needle has not moved very much, right? 5% of American US physicians are Black. For the past 40 years, that number has not moved. So we have to go further back into the education tree. I'm talking elementary school, create pipelines so that we can breathe life into the dreams of Black and brown children, so that they want to become doctors, so that they understand how to become doctors and health adjacent providers. So the comprehensive care model is the answer.
As a corollary to those great points, I'd say we know that so much of what happens related to healthcare outcomes is related to the environment in which folks live in, external to the healthcare environment. And so a failure to acknowledge that and a failure to remediate that where those exposures take place, we're doomed to continue this sort of what seems like an inexorable path of disparate outcomes. The second point I'll make as a corollary is that in addition to these tangible healthcare outcomes being disparate by race, like mortality of mothers and babies, we actually know that there are disparities in key process metrics. So there are a variety of things that we actually know can be effective in obstetrics and in other areas of medicine. And yet our ability to deliver those differs by a variety of factors, race being a very important one. So even as we try to learn new and better ways to do things, we ought to learn how to best implement the things that we do know work and do so for all people.
And I'm so glad that you mentioned pipeline. We're going to come back to that, but I do want to shift to more of a system or a policy level. And so, Dr. Jacobs, we know the Pennsylvania Department of Human Services has been looking at a variety of policy instruments, including looking at historical redlining as a key contributor to health disparities today. So can you explain to us about that work and also other things that DHS is doing to undo negative effects of systemic level, policy level things on health and to improve health equity?
Sure, yeah, thank you. So if we go back to the 1930s and 40s, the term redlining really originated there. And it was New Deal America. The Homeowners Loan Corporation went to certain racial and ethnic minority neighborhoods and designated them as hazardous. The effect of that was that businesses moved out of the area. It was difficult to get a loan. The wealth that families had built was oftentimes in their homes, and so by redlining a certain area, it made their home value plummet, and families lost their wealth. It became difficult to get access to healthy food, and the conglomeration and the intersection of all those things over several generations and continued segregation over several generations has led to profound geographic inequities that we still see today. So if you're born in northern Philadelphia, certain census tracts, your life expectancy might be 63. If you're born just a mile to the south, your life expectancy goes up to 87, difference of 23, 24 years. If you're born in a certain census tract in Erie, your life expectancy is 61. If you're born in the census tract next door, your life expectancy goes up to 82, a difference of more than 20 years. And so, and today you can look at the makeup of those neighborhoods, and they're racially segregated. The historically redlined ones are the ones with the poor outcomes. And to just give a sense of how profound that actually is, if we were to eliminate heart disease altogether, that's a life expectancy difference of about 4 years. So a life expectancy difference of more than 20 years just based on the block that you're born, like that's incredibly profound and incredibly depressing. And so part of what we've done in the Department of Human Services is we are really trying to look at communities themselves and identify the communities with the most profound levels of health inequities and designate them as health equity zones and target our investment as a society to those communities specifically. Because these are the same communities that have received historic divestment over generations. And so when people see statistics today where like COVID decreased life expectancy for Black Americans by 3 years and 1 year for white Americans, I mean, that's a shocking statistic, but it really is a statistic that is that fell on the pre-existing fault lines of society that have existed for generations. And so really by targeting those investments in certain communities, we hope to reverse some of those trends.
Thank you. Staying at a policy level and coming back to pipeline, but also continuing with other policy level interventions, what other system level or policy level interventions are important to undo the negative effects of historical constraints on healthcare today? So Dr. Flores, I know you've talked about pipeline initiatives, education and career pipeline initiatives. Would love to hear about that from you or others who are involved in that work, and also interested in this group's perspective on how payment models in healthcare can serve to drive the achievement of health equity.
So as this pandemic has shown us, and also other preventative and screening promotion programs targeted to our communities, they have shown that the most effective health promotion messages are delivered by people who talk our language, move their hands like us, they look like us, and they get us, right? So I believe that's the part of the success of the COVID vaccination program in Puerto Rico, where right now very close to achieving 80% vaccination rates, and also can explain the very high rate of donation of tissue for research that we see in our cancer biobanks. So I am personally aware of efforts in Puerto Rico at my institution, Ponce Health Sciences University, to train physicians that not only are from Puerto Rico or Latino, Hispanic, but also are fully bilingual, and they really understand the cultural context of the patients. And they, of course, go on and go into residency programs in the island and serve for patients in the island, but many of them are actually quite coveted here in the States, in hospitals and residency programs that serve people that speak Spanish preferentially. So I strongly believe that we need to invest in that pipeline of the new physicians and healthcare workers to incentivize people that not only are trained in cultural sensitivity, but that are coming from those same communities that they're gonna go in to serve. So we need representation of all the diversity of populations, of ethnicities in the States if we really want to make an impact in healthcare.
Any comments from the panelists on how payment models related to healthcare can help to drive achievement of health equity?
Yeah, I can take that, and also if you want to add. With regards to payment models, one of the things that we've noticed in Medicaid over years is these profound levels of inequities by race within Medicaid. And we've been talking today about maternal health outcomes and also infant outcomes. And so, for example, timeliness of prenatal care is something that has had an inequity for many years. And so just this year, for the first time, DHS put in place an equity incentive for the Medicaid MCOs that we oversee. So if the Medicaid MCOs hit national benchmarks, specifically within their Black population, and for exemplary care, they get an actual payout at the end of the year. And when we've rolled out a maternity care bundle payment, we have also included an equity component of it. So specifically within Black Medicaid members, if you hit certain national benchmarks, the providers can do better within those models. And we really are trying to put our money where our mouth is, so to speak, in that we really want these inequities to be decreased and giving incentives. We know it's bigger than just us as a department. It's bigger than a single provider. It's bigger than any kind of single payer. It is really incumbent on all of us to use whatever innovations we can and whatever research is out there to tackle these inequities collectively. And so we're hoping that by changing these incentives, we can collectively get there.
Dr. Livingston?
Yes, I agree with that, and I think it's a very impactful statement. I think that when we talk about how to address health disparities, it can't be just an issue for Black people. We have to look what happened with George Floyd. I mean, the entire world recognized that that was wrong. And so we need to continue to recruit people who aren't Black, who aren't directly impacted by this into it. And how do we do that? We create models where if you are a provider and you're addressing health disparities, then you should get reimbursed. So dissect the hospital, dissect the office, and say, if you're addressing colon cancer and help minimizing those disparities, cervical cancer, breast cancer, maternal morbidity and mortality, if you're actively addressing that, not just talking about it, but actively addressing it and working hard to eliminate that disparity, then you should be reimbursed. It's the recruitment model. It'll work.
One thing I'll add to this conversation, I'd say, is much like we work hard on scientific discoveries and sort of bench to bedside for interventions, or we think of innovative strategies to take care of patients and trial and test those. In a like fashion, the sort of notion of an incentive and payment structure to improve the health of a population, that's a really important thing to understand as an intervention on a population basis. And I think the more that we as a provider system can work with payers and with the government to be able to dissect this issue, we'll actually understand the best way to move the needle. And I applaud, in the state of Pennsylvania anyway, we have DHS and in our system at UPMC, between working with our provider side and our health plan, a really eyes wide open, willing to embrace new ways of doing things, and testing, trialing to improve outcomes. I think I feel really fortunate to be on that side trying to address these issues.
Thank you. Dr. Flores, we're so fortunate to have you here with us all the way from Puerto Rico.
Oh, yeah.
Thank you for
inviting
coming.
me.
And as we prepared for this, you shared some really important historical context about women's health in Puerto Rico that would be wonderful for you to share with the audience today. And also would love to hear from you about things that have worked in Puerto Rico to improve health equity that we may already adopt here but could potentially adopt with more rigor here in the continental US.
Yeah, so following up on the excellent keynote, I wanted to also highlight the history of population control that was experienced by Puerto Rican women and also women of color in the 30s and the 40s. This procedure called la operación, the operation, really was tubal ligation, and it was so common that it quickly became the only option or the preferred option for many women in Puerto Rico, so much so that by 1980s, 40% of Puerto Rican women were sterilized by tubal ligation. And I just wanted to bring that up because, I mean, if we don't want this history to be repeated, we need to recognize it and put it up front. So moving forward to today, it's notable that in Puerto Rico, most of the population really have access to healthcare, upwards to 96%. And it comes from two different systems. It would be the private insurance that you pay for, or your employer pays for, or the government insurance, which is financed by Medicaid. But as you probably know, Medicaid funding is capped for non-state. So Puerto Rico is right now, suffering from this lack of funding that really is impacting on the health disparities that we see in our population, from increased prevalence of chronic diseases, diabetes, cardiovascular, but also low birth rates and high rates of preterm birth. I mean, this is all caused by this limited funding in healthcare that we have, because as we all know, having access to healthcare is not the same as having access to quality healthcare. Now, despite all that, and I'm trying to find good examples of good things that has happened, well, we do have good rates of vaccination, not only COVID, but also HPV. But in reality, we still are suffering for health disparities. And within our population, even there are health disparities. A recent study that we conducted on women with endometriosis showed that those with the government or public insurance had less access to gynecologists, specialists, and treatments. So there are disparities within disparities, and really we are very far away from having health equity. And we need to do more research to really find what are the sources of those health equities if we want to solve them.
The last question, and I'd love to start with Dr. Cooper Owens, but I think we have time if every panelist would be willing to comment, is you delivered such a powerful keynote, and you teach, you're an educator, you've written a book, we've had this panel. What would you say, and then starting with Dr. Cooper Owens, how do we best communicate about the importance of historical context in advancing health equity today? Is it first-person storytelling? Is it, research, education? I'm sure it's not just one thing, but would love to hear from each of you about what you think some of the most powerful ways of communicating about this might be as we try to make it more present for everyone as we do the important work of achieving health equity today.
Yeah, that's a great question. Thank you. So you're right. There's not just one way. There are best methods I think we all can use dependent upon our skill set and our talents. So for me, it has been being able to contextualize what seems like anecdotal stories so that people see themselves. I'm also aware too of the enduring racial fatigue that white folk feel when they are not privileged or centered. So, you know, very much like I think Dr. Livingston said, how do we get folk who are not fatigued by these constant talks of equity and racism, and how do you get them to not see themselves as being indicted and guilty, right? So there has to be a way, I think, for us to be cognizant of that, to be respectful, and to not have these as kind of adjacent or attendant discussions, but they are always integrated. So for me, it would be, you know, to really be aware of what we already know in this nation, but also what the statistics have provided. For me, it is about contextualizing the past in ways that are accessible for folks. So I don't use jargon, I speak in an accessible way, I tell stories and I infuse it with humor, so that people can actually see themselves in these stories and experiences.
Thank you. Dr. Flores? Dr. Livingston?
I think the best way to answer that question is to be what younger learners can't. So for me, as an older, not too old, African-American OBGYN physician who is a department chair, I can say things, I can take risks that younger learners of color can't. I want them focused on getting A's in physics and getting excellent grades. And they may not be able to endure some of the battles that I can because there's this, I guess, less fear of losing. And so I think that once we reach a certain status, we are obligated to reach back and pull up and to widen the lane, not narrow it, so that young learners who can't say things because they should be busy doing the hard work, and then we take that weight off of them.
Thank you.
Undergraduate and graduate medical education, largely in the United States, tends to be fairly devoid and almost intentionally ignores the world in which it lives. I think it's seen as, in some ways, scientifically impure to pay attention to the environment, and that environment includes history, it includes these social determinants of health, and I think it will make for better doctors. I'm talking, I guess, specifically about medical education. There's other examples of this, but it's not a waste of time. It's not, oh, some humanities things for doctors and they don't need to learn that. It's actually essential to understand how the health of a population has reached the point it is and to be able to remediate it. And I think it would not be, I think the most important step is the philosophical embracing of the necessity to do so. The logistics of doing so and development of the curriculum will follow with great experts, but I think embracing the need to have this historical context and acknowledging environment is a really important sort of next set of steps.
Dr. Jacobs?
I feel like it's a really hard question. it's maybe, and I think that when we look back in society, we used to be a society that at least agreed on common problems. We could look at all data collectively and go, oh yeah, that's a problem, let's like solve it together. And I worry about just how polarized societies become in general, to the point where it's becoming hard to solve common problems. And so I guess the way I've approached it personally is that it's important to just start with data and stories and pictures and things that people can't argue with, and be like, and can't like retreat into their corners of like what they saw on TV that day or whatever it is, but really can kind of, if we can collectively look at data and maps and listen to stories and understand the humanity behind all of it, and then look at it each, and I'm just going to essentially agree with Dr. Cooper Owens, like look at it each from our own vantage point and identify what levers we have at our disposal, what power exists in my current position, what friends do I have? Like, there's so many kind of self-reflective questions that one has to ask, and that's a very personal thing, to figure out how they can make the biggest difference, and that answer is probably different for different people.
Well, so glad that the conference organizers put this at the beginning of the advocacy afternoon, because I think it's laid such an important foundation for the rest of the conversations. Please help me thank again Dr. Cooper Owens and our panel.